Okay. Well, good morning, everybody. Good afternoon, good evening, wherever you're calling in from. We're very excited to have our Alumni in Action series continue. We heard Jude and Carol a couple of weeks ago, which was wonderful. Today, of course, we're also reflecting on the legacy of our dear beloved brother and teacher, Paul Farmer. And I think there's no more fitting tribute to Paul on this day than to be talking about palliating the suffering of people. Paul, as we all know, hated to see suffering. He was personally wounded by every person that was in pain, either in pain of poverty, in pain from a disease, in pain from sorrow. And I think, palliative care is really about taking care of people and easing their suffering, easing their pain. So many different ways to do that. Paul used to talk about giving patients packages of love, which might be a book or an iPod, or of food or a hot meal. There is, of course, the medical part of palliation, which we'll be talking about today. Component for people who have, pain that can be eased by medicines. When Dr. Christian Tazimira came to our program several years ago, he really wanted to look at access to palliative care in his home country of Rwanda, but as a model, as a way of looking at it across Africa and even the world. And he was very fortunate to have Dr. Eric Krakauer as his mentor, somebody who has been fighting for access to good, high quality palliative medical care for many decades. And so we're really fortunate to have Christian and Eric, Dr. Ntizimira and Dr. Krakauer today with us to talk about their work in palliative care and how they see it as part of a pathway for fairness and justice and to alleviate suffering. So thanks, Christian and
whenever you're ready to share.
Eric, or?
Go ahead.
Okay.
Do you want me to begin? Okay, well, I'll begin. So Joya, Dr. Mukherjee, thank you so much for inviting us to speak. And before going on, I just want to acknowledge the enormous encouragement and insightful advice over decades from Paul Farmer for this project of making palliative care accessible to all who need it. And as Joya said, it's really about relieving suffering. Whatever suffering isn't being relieved by other means, such as treatment of disease, that's what palliative care is for. So I think both Dr. Christian Tazimira and I sort of feel that it's our responsibility now to, more than ever, to continue this work. And we're enormously grateful, both of us, to you, Joya, and to Paul, and to the Master of Medical Science program in Global Health Equity for enabling Christian to pursue this work. So thank you. Perhaps by way of introduction, I'm Eric Krakauer. I'm a palliative care specialist physician. I practice at Massachusetts General Hospital and within the Department of Global Health and Social Medicine at Harvard Medical School. We're building a program in global palliative care, along with colleagues from throughout Harvard system and around the world. And one of our stars and leading theorists, I think, is Dr. Christian Tazimira, from Rwanda and founding director of the African Center for Research and End-of-Life Care, with whom I've had the pleasure of working for many years. Dr. Tazimira, please.
Thank you, Eric, and thank you, Joya, for the invitation. It's a really pleasure to be with Eric and discuss about our work. So I'm going to share my screen. So first of all, I would like to pay a tribute to Dr. Paul Farmer. I know we can talk a lot about Dr. Farmer, and especially my time when I was in the US doing my master's program. But there is something special for me. I remember about Paul Farmer. Paul Farmer was a human being. For me, that is the only definition I can remember from Dr. Paul, because 2 weeks before Dr. Paul passed away, I lost my brother. My brother died 2 weeks before Dr. Paul passed away. And we were during the funeral, and I saw on my iPhone, and I saw a message, someone from Boston, the number was from Boston, and it was Dr. Paul. I don't know how he get my contact, but he wrote to me as a Christian, I heard about the loss of your brother, and my deeply condolences for you and your family. And I was very surprised because it was a sudden death, and we were just in pain and grief. And he heard about that news, and he sent me a text message. I was very, very surprised, and for someone who was really busy and traveling around the world, try to changing the perception in global health, I've been really, really touched. It's for me, it's a great moment to present this work, and very inspiring by Dr. Paul. So I'm going to talk about decolonizing palliative care, and my mentor here, Eric, will also share some views we discussed many years ago and during our work. As Eric said, my name is Christian Tazimira, and I'm Executive Director of African Center for Research on End-of-Life Care and MMSc Class 19 and Alumni. So let's first start about Rwanda. Rwanda is called the land of thousand hills. I live in Rwanda, and Rwanda, it's almost 12 million people, and almost 50% of population is under 8 years. So the GDP per capita, changed completely from 1994 to recently 2018, which has moved from $200 to almost $900. So the population density, it's almost 500 people by kilometer square, and it's a landlocked country. So this is now 28 years after the genocide against the Tutsi, where 1 million people died in 100 days. And it's not only 1 million people died during the genocide, but also we lost our sense of humanity. And I strongly believe that the concept of palliative care will contribute a lot to bring back the sense of humanity we lost during the genocide. Why? Because palliative care is not only about withdrawing or withholding medication, it's about dignity, humanity, and Ubuntu. So what was the background of palliative care in Rwanda? So a study done by the Penn Policy Study Group from the University of Wisconsin between 2007 and 2009, so that morphine used in Rwanda was only 0.2 kilograms. So per capita was less than 0.1. And you can imagine per death in pain was only 10.6 milligram. And the 0.2 kilogram was estimated to treat only 27 people. So the coverage of death in pain in treatment was only 0.2%. So the morphine need in the whole country was estimated at 97 kgs. So which you can imagine, more than 85% of the population was really dying, suffering with the moderate and severe pain. So what was the challenge that time? One, it's opophobia, fear of using opioids, and also doctors' attitude regard pain. I remember when I was in medical school, one of my teachers told me, don't treat pain at all, because if you treat pain, how do you know that your patient is still alive? So if you treat pain, that will be the only signal you have to know that your patient is alive. So I took it for granted because our attitude regarding pain was really careless. So the protocol, when I was starting doing practice medicine, so the protocol also was really a nightmare. So if you need 1 amp of morphine, you need to use a red ink, 3 signatures just for 1 amp. And that's some, of course, no multidisciplinary approach to support patients. But in 2011, Rwanda became the first African country to launch a standalone national palliative care policy, strategic plan, and implementation plan. So which lead the country to really see how palliative care can be moved from the hospital to the community. And that time, some of the study we done with Eric was to see how it will be the support from community health workers and how they can support the patient when patient will be discharged from the district hospital. And the government, the plan now from the government is really to hire more than 1,000 palliative caregivers and making sure that patients at the community will be well served. And also, Rwanda decided to produce its own morphine, and since 2013, and here this is the laboratory at Butare, which in South Province, where now the Minister of Health starting to purchase morphine powder, and the morphine powder is reconstituted as morphine syrup, which is now free of charge for all patients who really suffer from moderate and severe pain. And we can see the change since 2012, 2013, and now almost the government is using between 5 kgs and 10 kilograms of morphine. But of course, we need to continue to train physicians and the nurses and all clinicians to make sure that patients at the community level will never suffer again for severe and moderate pain. So, and also the law, the governing law, and the law governing the narcotic drugs and psychotropic substance and the prostitute in Rwanda say that people have been trained, not only physicians, because the experience of using IRT at the community where nurses can, the task shifting program, where nurses can be able to prescribe IRT for HIV patients, was using on the same to say now qualified midwife or nurses authorized to exercise the profession can be able and train to prescribe morphine, will be able to prescribe at the community level, which will be a big step for when the implementation, of course, will start. And this is clearly a simple image of palliative care program in Rwanda. What we expect in the coming years with from the government, also by the support of local and international partners, to making sure that it will be a very comprehensive program and really integrated in the public health system. So how I became a palliative care physician. So my dream after the genocide against the Tutsi in 1994 was to become a breast surgeon. Until I met a very young guy at Kibagabaga Hospital who was really dying in pain. So the patient was really suffer from HCC, hepatocellular carcinoma. It was a last stage. And it was my first time to see a patient who really was really in pain. It's not only physical pain, but it was also pain with suffering. And the sad story is his mom came to me and leaned before me and asked if I can be able to use just a simple thing to help him to sleep and wake up no more. I feared to prescribe morphine because I've never been trained to prescribe morphine that time. And I felt that I failed twice. I failed as a physician because morphine was, even if a small quantity was available in the hospital, but I feared to prescribe it because that time we thought that if you prescribe morphine, morphine hastens death. So the patient will die and will go to the jail. But also I failed as a Rwandan because in our culture, when an elder person kneels before a young person, that means culturally you have failed. So I went back home and asked myself, why am I spend so many years in medical school if just my role is to witness social injustice and pain? So I changed completely from my dream to be a surgeon to become a palliative care patient. So why decolonizing palliative care? Why is it really important? So first of all, decolonizing is a social justice and equity because the current model of advanced planning and the end-of-life care is have grown out of the Euro-American clinical and culture experiences. So it's really important to create a local relevant and community-centered model of care, which ensure the dignity and well-being of patient and value the society. And also, this is the biggest, Eric will talk more about it. This is among the work Eric done, and of course, later Paul Farmer, Dr. Paul Farmer, to demonstrate how social injustice is really, it's evident in the world, especially using morphine. You can see here, only 3 countries are using the 15% of the 97% of the morphine consumption in the world. So it's Canada, US, and Australia. And you can see Africa, how it's really, you can't even recognize any country there. So another point is, based on the my work field here in Rwanda during my master's program, supervised by Dr. Eric, we discovered that there is a historical shift in the meaning of death itself, which influenced the patient end-of-life perception. So in traditional Rwanda or in pre-colonial Rwanda, that time, death was viewed as an achievement. Why? Because it was considered as part of the normal life and a natural phenomenon. And it was viewed as a natural reprieve and reward after the well-lived and fulfilled life. And it was rewarded to be a spirit, because when someone was dying, so all the family was putting together and making sure that the person will die on a very good condition. And because they were preparing for that time, death was not a limit of life. Death was the continuity of life. So after death, life continued, and that person will become an ancestor, and it will become a protector also from the family. So it's why in Rwanda, when you introduce yourself, you don't introduce as, I'm not introduced as a Christian, but introducing by the name of my father. We introduce the name of my grandfather and grandfather, because that is the way the spirit of that person was continuing to link in the family. So some of the quotes we collected during our time. So one of the participants say, so the Rwandans believe in the highest one with Abazimu, which is ancestors. And Abazimu, the spirit of the ancestors, they are Abazimu, good spirit, interested in what remain known as Igambwa, a protective spirit, an intercessor who intervene between me and Imana, which is God. So the second point is good death and bad death. So we know that when people are talking about good death and bad death, it's more focused on medicalization. But that time in pre-colonial period, good death was viewed when the social culture engagement on family members or a community during the dying process. So it was a privilege, not a hardship, to support and to be there when someone was dying. And also, that was a good death. So having children was the critical criterion by which a person in the society was judged. It represents the highest achievement and which define a good death. So the perception of bad death was interpreted when a person died alone. So without children, a wife and old family members. So the postmortem ritual was very important. So good death and bad death was not related to access to medicine or traditional medicine, but it was really the involvement of the community which define if it's a good or bad death. So one of the causes is such a person will be said to have died with a piece of charcoal in his hand. So if you died alone, it's like you hold a piece of charcoal in your hand, because that is the suffering, because in dying, no one to help. When someone is said that to have died poorly, it means that he suffered alone with no one handing him. So which is on sense, so dying poorly or bad death was really more focused on the community than access to traditional medicine. So how death shifted to become a source of fear? So the adoption of a Christian belief in the colonial period shifted the paradigm of death, and the perception of end of life changed. So the concept of hell and heaven, which is a choice, become a choice now, was not familiar in Rwanda tradition prior to colonization. So death as a penalty and the sanction increasing fear and changed the perception of death during the dying process. So it's changed completely how now I can understand why now it's difficult, even for us physicians, to discuss about death, because the Christianity brought another paradigm which is not familiar in our culture. So the ritual of ancestors changed to the ritual of evil spirits. So Abazimu, which is ancestor, become a evil spirit, and Ikuzimu, which is the place where ancestor was living, is now translated as hell. So you can understand how now it's really difficult to talk about death. And the quote, but fear of death as a sanction, having a duel is either hell or even. This idea of strictly Christian, death is more threatening today compared with before. The word of death are stronger than yesterday. This is the quote for one of the participants. So another point we need to think about the colonization of palliative care, it's about cultures matters. I remember my first trip in the US in 2011. It was really a nightmare because I didn't know about any American culture. And during the interaction with Americans, someone used to tell me, oh, this is my personal space. I didn't know what personal space means. I didn't know where is the boundaries. So then I just realized later that cultures matters, because in Western culture, individualism, autonomy, privacy is really important. In our culture, family, it's an ecosystem. Extended also family is really important. In terms of family values, nuclear family and the equality in Western countries is really important. Extended family, respect elders, looking for the lion hierarchy, who is the elder, the most influential person in the family, is also really important. Disease and illness, it's caused by a specific agent. But here, when I'm talking to my patients, they think maybe there is something they did against the ancestral world. And also there is a positive fatalism within thinking that there is always something good ahead. So pain, experience in Western country, the concept of total pain, stoicism, which is really important, resilience in Rwandan culture, death, which is a private in the Western country, but for us, it's funeral, it's a major social event and even an accomplishment. And I just realized last time when my brother died, it was more social when people gathering together and talking about his accomplishments. I believe as well. So there is some, we can talk about the definition of decolonization, but I'm not going to talk about deconstruction and the reconstruction in decolonization. I just want to talk one point for me, which is really key in palliative care. It's about value expertise by experiences. So the African Center for Research on End-of-Life Care came when we discussed with the RIC, and after my time in Boston, I came back and said, most of the research I read was just to compare the two sides of the world, what we have in low middle income countries, what we don't have in low and middle income countries, what existing in high income countries. And I came just to realize no one never asked me, how do African patients die? And how would the African patient like to die? So that was, for me, the ACREOL was a contribution to decolonize palliative care, to ask the right question to the right people, and hear from them what is really, really important. And from that, I came inspired by Paul. I remember one of the class we had with Paul. Paul was really encouraging us to write and say, you need to write a book because you have many stories to share. And it's just recently, 2 years ago, then I was starting my project to write about the safari concepts, how every journey matters. And the book is in progress. I hope the book will be published this year. So I just realized when I'm talking about safari, from my colleague from Western country, it's about visiting animals in the park. But when I'm saying safari in Swahili, it means journey. So I try to combine the both and see what will be the best way to use and understanding the pathway of the patient. So the book is talking about decoding the language of suffering from the family members. As you may know, when we're starting call the family meetings, so you can imagine in Africa, if you call a family meeting, how many people do you expect will attend the meeting? So almost it's from 10 to 40 people per meeting. So in the last 10 years, I collected, from my observation, more than 800 family meetings during the last 10 years. And the idea here is to value expertise by experiences using the empirical approach. I was very naive that time. Then I just realized my observation, they call it ethnography when I came in Boston, but I didn't know. For me, it was obvious. I observed, I discussed with the family members, and from the observation, I can categorize the type of suffering and also to develop a different language which can be used and also to relieve suffering from the family members as well as the patients. So I came back with the 12 animal archetype, which describe 12 language of suffering to different behaviors. Let me show you just some examples. And also the idea during how can you convince 40 people about something really important for the patients? So one of the key points during the safari concept was to identify who is the lion or the lioness of the family. It could be the elder of the family, it could be the strong man, it could be the rich person, the man woman, it could be the person well-educated, or someone who's really identified by the group because of the disease. So it's a very dynamic way. It's not only the elder of the family, it could be someone else depending on the need to support the patient. So this is one of the examples. I define what to call the JIRA family members. So the JIRA family members are family members who came with very unrealistic expectation, or they ignore the reality of local resources. Those are most family members who live abroad in US, Canada, and Australia. When they came back home and they see the patient dying at the district level, they come with a very unrealistic expectation. You can hear family members asking if you have a CT scan, MRI, if you have an oncologist, chemotherapy at the district level, which is totally different. So our interpretation is not to stigmatize the family members. So the JIRA suffering express mistrust of the local health system compared from the West, where they came from. So our management, so it's difficult to go high than a giraffe during the discussion because they have an important ego, especially when they came from Massachusetts. Sorry, Rick, it's just I'm laughing. It's just a joke. So I think the best way to manage the family, it's just confidence with humility is the best answer. So the hyena family members, it's family members who have behavior of conflict. So the death or the disease in the family brought up some conflict, inner conflict within the family, which is maybe ignored or neglected, but the dying process of the patient brought up that conflict. And there is a lack of dignity, empathy, and careless. So hyena suffering express an antagonist feelings. One, because the patient is the source of conflict, but also the patient is the social connection of the family members. And the family, they are fear to live without that conflict, because the conflict become the second nature of the family members. So the management, when we have this kind of family members, we never hug with the hyenas. It's really difficult because they will eat you. You can understand. So the first action is to protect the patient by working with the lion of the family. And also we try to think about legal aspects to protect the family members. And the last example is about torture suffering. So they believe about cure, miracles, philosophy, traditional healings, and religious. We'll see those people who have a strong shield, and everything you're talking about medication, they will think about miracles. Everything we're talking about advanced care plan, they will think about religious miracles. So our interpretation is that torture behaviors express a feeling of second chance. So because the family think there is a left behind purpose and goals, or an accomplished or unfinished work. So the management is language matters. And I tried to teach my team and say, if it's a Christian, and here in Rwanda, we have a language for Christian, they know better. They said, yes, Ashimwe, which means Jesus be praised. And it's a very simple way. If in the Semitism, we can say, Salam alaikum. It's a very simple. And then you can break the ice instead of coming with the white coat and the stethoscope and say, oh, this is the plan for you. So it's better to increase our communication. And another contribution to decolonizing, it's about the Ubuntu palliative care. Ubuntu means, try to translate it or to explain, people are people through other people. So as most African, you know, we don't define ourselves as a small isolated component. We define ourselves as a soul. It's more about humanness, caring, sharing in the respect, especially compassion care, which is now really important. And we need to integrate Ubuntu as one most of the components, and making sure, especially during the COVID-19, when most of our sponsors and money withdraw, but care continues, because care goes beyond financial issues, because care is really rooted to the human part of the patient and the family members. So what the lesson learned? One, I've learned from my own culture that we have a saying. I know Eric likes this saying. So when you are well, you belong to yourself, but when you are sick, you belong to your family. So that I just realized the last 10 years, I set up a small approach. I called it the butterfly approach. When on my left wing, I can have a patient autonomy. It's about privacy, choice, and expectation from the patient. And on the right wing, it's the community responsibility. It's not that the community responsibility will cancel the patient's autonomy, and the family are not the barriers to the patient management. So then I try to combine the two and to have a decision making, which is really inclusive and include the community to support the patients. Second, education. Something I've learned from Eric the last 10 years, Eric taught me something very special. And he said, one day student, one day teacher. When I met Eric, of course, he was an associate professor in Harvard already, and I was just only 5 days training in palliative care. But he was really asking me, what do you think about this? What do you think about that? What do you think what will be the best question? And I've learned, despite all the publication he did, he was still on the process of learning. And I just realized that education doesn't necessarily mean duplication, but rather than adaptation. So before to adapt, we need to adopt. And that is really important. But sometimes we come with tools, we come with many materials, and we ask people at the local level, can you adapt this material, without even asking if this material could be adopted by the local population. So on my sense, we need social fair, social justice and equity by starting by adopting what is really existing to adapt to the reality. And meaning is a very important. I think Eric will talk more about it. So meaning is as a social justice and the equity. We need to remember, based on the research we did, that traditional palliative care and end-of-life care existed before modern palliative care exists. So they didn't call it a palliative care, they didn't call it end-of-life care, but that's the component of palliative care was existed in that time. So, and it's really important when we think about access to palliative care at the global level. My understanding is global is local, as local is global. So it's difficult to connecting communities without connecting identities. So if we don't connect identities, it will be really difficult to get at the global level. And also we need to not be trapped in international standards in palliative care, which could become a source of social injustice, especially when some people, I remember one of the first time I traveled in Canada, during the meeting, it was 8 years ago. And I was trying to present, the small beginning of palliative care at Kibagabaga Hospital. And during the audience, someone said, oh, this is not palliative care. Because for him, there is a standard which is not a standard used in the US and Canada. And if you don't get on those standards, that means we don't provide in palliative care. So sometimes international standards, we can be trapped and think that international standard in palliative care is the best, but it could become a source of injustice if you're not taking into account crucial for dignity of the patient, some element which is really crucial for the patient, the family, and the environment. So my conclusion is a simple but not simplest. I just realized that the way people die can reflect how the society lives. And I took this painting from Jean-Louis David, a French painter, which you can see Socrates was ready to drink the poison, but also continued to argue with the population about his philosophy. So you can see how your death can represent the way the society lives. So, and for us, if we need social justice, and if we need equity, we need also to focus for those who are dying, because humanity is not about the diagnostic or the prognosis. It's just about the person. I asked my friend who is a photographer in Rwanda, and I asked him, how do you see suffering? Can you just tell me, I need your lens, I need your photo to explain me, how can I explain suffering? So then he brought this photo, dead hand with bright screws in the hand. So I think the question is, what do you see? And I know most people will be focused on the screws instead of the dirty hands. And this is how it's happened when people don't think, or they don't value some of the elements existing at the local context. That which is really important. Even about suffering, sometimes suffering, I can consider suffering about those dead hands, about the person, because people really focus on the disease, but not focus on the person. And the last point is about naked but not ashamed. I remember this case very well. This is the patient who was really dying with HIV and cervical cancer last stage. And we went there with a nurse. She was really sleeping on the mat. And we bought the mattresses and we bought the bed sheets and the blankets. And I was so heavy to see someone really dying in this condition. Then I was sitting there and I took just a book note and I was starting writing about everything I was passing through the last 10 years. So I just wrote a small poem. I can read it just to finish. I wrote about feel naked but not ashamed. So I feel naked when I witness patients still dying with horrible pain in hospitals and at home because they can't get access to strong opioids. I feel naked when I see my colleague afraid to prescribe a simple dose of morphine to reduce the suffering of patient because of myth. I feel naked when people call me grave digger because they wonder why I take care of those already condemned. I feel naked when I see the suffering of family members and caregivers, helpless and hopeless to support the patient as they could wish. I feel naked when I visit patient and family members and I see social, psychological, and the spiritual pain. I cry in the palace of God because I don't know where to start. I feel naked when the dignity and value of patients are viewed through the lens of the disease, not the humanity. I feel naked when I see that access to treatment depends on your place in the world. I feel naked when inequity, inequality, social injustice, and the culture of me, of I, prevails of the connection between people and culture. I feel naked when people are happy to publish data from developing countries, but less age to support those countries. I feel naked when sad when colleagues from developed countries claim, what are you doing is not palliative care. They focus only on comparison, not to the reality of our compassion efforts to support patients and family with our limited resources. I feel naked when I read expression of gratitude, satisfaction, hope, and life in the eyes of my patients and their families, just because we are there. But, yes, but I'm not ashamed, because we are not beholden to hate, guilt, fear, death, or stigma, but to life, hope, dignity, and Ubuntu. I'm not ashamed at all, because though I cannot do everything, but I must do something. I'm not ashamed at all. So I would like to acknowledge my mentor, Rick Krakauer, Professor Boningebe, Mary June, Joa, Christina, and Bailey. Thank you so much.
Thank you so much, Christian. That was just excellent. And I love the way you bring in culture, but you don't use culture to say these things aren't important. You know, sometimes people say, oh, you know, maybe people don't need morphine because they have spiritual beliefs, but you're tying these things together in such a holistic way. And I really appreciate that. Does anyone have any questions for Christian?
Well, may I make a couple of comments?
Yeah, please, Eric. We'd love to hear your commentary.
Well, I had written down a bunch of notes, but I'm going to ignore those because I think the points I want to make are really quite basic. And again, this is all inspired by Paul, really. And it's this concept of openness to others. As we all know, Paul did not accept and has inspired us to not accept that the poor shouldn't have access to high quality healthcare. And as we all know, he had no tolerance for that intolerance, for the idea that you can't treat AIDS among the poor, you can't treat drug-resistant TB among the poor, you can't treat cancer among the poor. But what Paul did, which was also extraordinary, was to recognize that while providing the fruits of Western culture, which is Western technology, there also needed to be a humility and recognition that different people suffer in different ways, and that those wonderful technologies and techniques to prevent and diagnose and treat disease need to be, as Christian says, adapted to the local culture. Now, that doesn't mean, as we've heard over the years, that, oh, you can't treat AIDS in Africa because Africans can't tell time, as we heard from top UN AIDS official years ago, or that you can't relieve pain among the poor. You can, but there needs to be an openness to other ways of thinking and living and other ways of making meaning. And I think this is, for me, these are Paul's two great examples. Don't accept limits for applying the benefits of Western culture, but don't assume that you or that we as Westerners have all the answers. In palliative care, and I'll just make this final point, you know, I have, it's a great joy to work in palliative care, especially with my colleagues who, and there are too few of us, who work on global palliative care, trying to make palliative care accessible to the global poor. And these are really wonderful people by and large, with good hearts. But as you may know, some of you may know, back around 2007, Paul infuriated a lot of my colleagues by saying something that was not well understood, but was just Paul kind of challenging the palliative care world. He said that too often palliative care is used as second-rate care for the poor. And what he meant was he was referring to comments by very well-meaning colleagues who were saying that palliative care was the only feasible and humane response to AIDS in Africa. And this was unacceptable and should be unacceptable. And I think Paul's comments were then a challenge to say, of course, we need to treat AIDS in Africa, and palliative care should never, palliative care for the poor should never be a standalone kind of endeavor. It needs to be part of a project to make accessible to the global poor disease prevention, early diagnosis, and treatment, and palliative care. All of them have to go together. Otherwise, it's unjust. So I think that there's been, I think it's changing, but as palliative care was a response to Western medicine that forgot about human beings, it began to focus over the years with all these great technological developments on super specialization. Doctors became specialists either in one kind of disease like cancer or infectious disease, or one kind of technical skill like surgery or pathology, or specialist on one organ like hearts or lungs or kidneys, or even on one kind of molecule. And there was a forgetting about the whole human being and the family. Well, palliative care was a response to that. And that's wonderful and really important. But then there was a failure to recognize that different populations suffer differently. The assumption that the patient always has to be told of their diagnosis and only the patient can make decisions is a cultural imposition, a kind of Western arrogance based on the Western focus on the self. That medically, well, I mentioned about how medically unserved populations, the failure to recognize that medically underserved populations with curable or manageable diseases also need palliative care. Even in the WHO definition of palliative care, it states that palliative care regards dying as a normal process. That's written by a Westerner. It's maybe normal for people who have access to all kinds of treatment, but a young person dying of a preventable and treatable disease who's dying, that's not normal. It shouldn't be considered normal. And the WHO definition also states that palliative care intends neither to hasten nor postpone death. Well, again, if I can manage AIDS, if I can control the cancer, if I can manage the heart failure, absolutely I want to postpone death, and if the patient will have an acceptable quality of life. So I think that what is happening now, and this is for me the process of decolonizing palliative care, is to recognize that yes, we have a lot of wonderful means to relieve physical and psychological and social and spiritual suffering. And again, I want to emphasize that Partners in Health and Paul and Joya's work has been the model in my work with WHO for relieving social suffering in particular, as well as psychological suffering. But there needs to be a recognition that as efforts are made to bring these techniques of palliative care to the global poor, there needs to be an effort to incorporate and rethink salubrious cultural values that can make serious illness and the dying process more meaningful, more comfortable, and more positive in each cultural context. And that is what Christian is doing in his study of death as accomplishment in Rwanda. And that is what is happening in China with a project led by Arthur Kleinman and Professor Jing Jun at Tsinghua University, studying filial piety as an important cultural concept, and what should happen in cultural contexts around the world. So thank you for this opportunity, and thank you, Christian, for the work you do on teaching, on educating us in palliative care about our own lack of insight, of our own, shall we say, lack of humility and lack of ability to understand Ubuntu and to be open to others. Thanks.
Thank you, Eric.
Thank you.
So if there were questions or comments, please, for Dr. Tazimira.
If you have questions, please feel to put them in the chat or raise your hand so that I can allow you to talk. I know Susanna Arrego, she had a question. You have one right now. All right. Okay. Susanna's question is in the chat, and she wanted to know, Christian, she wanted to know if your team uses the McNamara criteria to enroll patients in the palliative care program.
That's interesting given the work.
Yes. Oh, sorry, can you come up again, the question? Sorry.
Yes, of course. She wants to know, so just some background, Susanna comes from Colombia and she's interested in how she could maybe apply some of your work in Colombia. She wants to know if your team uses the McNamara criteria to enroll patients in the palliative care program.
Well, thank you, Merlin, and thank you, Rick, for the comments. And I really appreciate, as you said, it's still, it's a win-win situation. We need to learn from each other, as you already taught me, one day student, one day master, which is really important. So for the program here in Rwanda for palliative care, we are lucky to have the government supporting us. So we don't need to create a parallel system, because the government of Rwanda really focused that everyone needs to get access to palliative care. Of course, we still have some challenges on access of palliative in the community, but still the gap identified during the implementation of the palliative care program was a lesson learned from the government to know how to emphasize. And it's why community health workers were being engaged, because community health workers was really working a long time ago for different health system. And it was really now important to see how, especially for palliative care, those people will be one to identify patient at the community level, because, you know, using the health system, it should be easy when the patient is identified from the referral hospital and you sent to the district hospital. But sometimes you have patient move from the hospital to the community, and is way to identify, of course, is based on the criteria from the government said, oh, these people are we putting on the program of palliative care. But I will go back to the work I've been done to the Lancet Commission when Eric was able to identify some of serious health suffering, and which we can have a huge number now of conditions could be put on palliative care. But that also will be based on the capacity of the country to be able to diagnose, those conditions. And as soon as we have more and more skills, I think the country will be able to make those people on palliative care. But if you're using the definition of a WHO, palliative care doesn't mean end of life care. Palliative care starts at the beginning, from the diagnosis to the end of life, or the life until the end, and even after, because it's taking care also the patient and the family members as well.
May I make a comment also? This is in response to a long comment from Dr. Seguro from Indonesia about the lack of access to opioid. And she says prayers are seen as the savior to take the patients to heaven. This gets back to this idea of openness to others, I think, and decolonizing, but that goes both ways. I think that in many places where, just to talk about pain as one symptom, where there were no opioids available, and so there was no access to pain relief, patients don't expect to be able to get pain relief, and therefore they don't even ask for it. And I failed miserably to learn Kinyarwanda during my time living in Rwanda, but one concept that Christian taught me was kwihangana, which which is something like, and Christian, correct me if I'm wrong, patient stoicism, forbearance, willing to bear something without complaint, something like that. Both in Rwanda and in Vietnam, where I also work, when I see patients, I know they're in pain. I have no doubt that they're in pain, and I ask, "Are you in pain?" And the answer is no. And I'm thinking, okay, why is this patient telling me no? Is it because, as sometimes I think I've found out is the case, they don't want to admit to it because they feel that would be disrespectful to me, the gray-haired doctor? It'd be like saying you're a bad doctor. Or is it because it's not considered socially acceptable and polite to complain? Or why should I bother saying I'm in pain? I know there's nothing that can be done about it. So part of the effort of implementing palliative care with colleagues in the developing world is to help patients and families and colleagues understand what can be done to, what some of these technologies are that we have, like, pain relief technologies, relief of nausea, of dyspnea, of seizures, of whatever the symptom is, that it's not necessary to endure pain. We can treat it and thereby help patients to be more functional, be more interactive, and make to cite Christian's example, the celebration of life as accomplishment near the end of life more possible and more meaningful. Or just to cite another example, in East Asia, where a lot of children consider it to be their responsibility to insist on all life-sustaining treatments for their 95-year-old cancer-ridden, very frail and demented grandparent, because that's their obligation. But maybe because of the technologies of life-sustaining treatment that have kept people alive, that have only developed over the last several decades, there needs to be a rethinking of filial piety so that people might understand that the best way to express my filial piety is to protect my vulnerable grandmother or grandfather from mechanical ventilation, cardiopulmonary resuscitation, hemodialysis, not insist on it. So there needs to be a thoughtful merging of the Western technologies with the local culture, which requires humility and openness. And that's how I would respond to Dr. Seguro. Prayers are great, nothing wrong with prayers, but we can relieve pain also along the way. Patients don't need to suffer. And Christian is showing us one way to do this in the culture of Rwanda.
Yeah, I can. There is also a question from Diana Ferreira. Merlin, you want to read it? And okay.
From Diana in Australia, she says, I love the presentation, Christian. Taking Eric's point, I was wondering, how do you manage disclosing information to your patients if the family opposes to full disclosure? This is certainly a problem in my country, and we are told to disclose information based on Anglo-Saxon literature. So,
okay, thank you, Diana. I think it's one I said. First, before to adapt, you need to adopt. And one thing I've learned from my small experience doing palliative care in Rwanda, the last 10, 12 years doing palliative care, I've never been contacted by the patients. I'm always being contacted by the family members. It's the family members who call me, approaching me and say, Christian, we heard about your work. We have a patient here, which is totally different in Western countries. Because when I did my observership with Eric and MMSc-GHD, patient is in control about information. Patient is the one who has to decide who has to be on board. And in Rwanda, it's totally different because the family is already on board, because there is a community responsibility. And it's why the Safari concept came, how to manage the privacy expectation decision from the patient and also from the community responsibility. And one not exclude other, because sometimes we say, I heard so many, my colleague, when I was starting the family meeting, my colleagues say, no, that will not work because family are complicated. Family are the barriers. That will not work. But I say, no, there is a way. They are suffer as well. So when you know the language, when do you know the language? If I know that it's a Jura family members, I know it's the people came from US, from Boston, from Australia, and they came with the perspective of Western countries. We need to comfort them. We need to give them a confidence that we are able, we've been trained, we know what we are doing. Even if the resource is limited, doesn't mean the skills also is limited as well. It's only about the resources, but the skills and the willing is there. And when you find the right language to talk to the right people, it's always bring the right decision. So, and on that time, information is keeping between the family, because patient as not considered as an isolated component out of the family, is part of the family. And it's why the information is really shared. So it needs, Diana, to be understood based on the context, not based on the literature or any kind of standard. Otherwise, we can miss the targets.
Moving on to Hiba Osman, he would like to know if you've done any work looking specifically at communication strategies and palliative care in Rwanda.
Yeah, it's the Safari concept. It's the best way. So I have 12 animals, defined 12 kind of family members, from the giraffe to the porcupine, hippopotamus, elephant, snake, ostrich, ants, all those kind of language. It's a type of communication, because I just realized I've never been trained in communication in medical school. I've never been trained to talk to the patients. I've been trained to talk to the disease, not to the person, until I realized there is a gap. Then I have to shift my mind and to try to talk to the patient. But I need to train myself and learn how can I communicate with the patient first but also how can I communicate to the family as well. So then that strategy of safari, which is, a journey, can help me a lot, because when I know that I'm talking to Aina families, I know exactly what they expect, and I know exactly which of language. If I'm talking to another group of family members, is the same. And this is, for me, is the best. And since we started doing the last 10 years, I think the last meeting I had 2 weeks ago, it was almost 40 people in the room. 40 people came because they find themselves connected to the patient. And I have no right to say, I need only 5 people or 2 people. It's themselves, they define who is connected to the patient. And the good thing in advocacy, when you talk to 40 people in the morning about palliative care, you have the rest of the village know about palliative care, which is cheap and a very fast way.
Thank you for that. I know that earlier in the talk, Susanna also asked a question about how you manage palliative care for children. Would you be able to speak to that at all?
Yeah, I have to be honest, that is still a challenge. I think Eric, the last time Eric was here 5 or 6 years ago, we trained people, including pediatrics and palliative care. But until today, that's, I think, one of the discussions we had with Eric in the future to continue the legacy of Paul Farmer, because I know in Butaro Excellence Cancer Center, supported by PIH, they did a very good work for supporting children with the cancer. And we plan with Eric to really emphasize on that, because we did so many work for adults. So I think that is now the time to shift on pediatric palliative care as well. So it's still challenging on that sense, yeah.
A question in the Q&A was from Cyrus Yashimoto, sort of curious for you, Christian and Eric, looking at stoicism among patients and handling their pain. I'm not sure if there's anything you could speak to about the difference between patients that you found, or anything about stoicism that might impact the way you deliver care.
I can start, then Eric will say something. Stoicism is really important in Rwanda. And as Eric said, kwihangana, it's a very strong concept. It doesn't mean you don't have a right to express your feelings and emotion. No, it's about, you need to make sure that your emotions and feelings are not about the other people. So it's more about caring about other than yourself. Because if it's about you, you can do everything you want. But if you think it's a community-centered approach instead of individual approach. And it's really important. But on that sense, stoicism brings also resilience. How you change suffering to a very positive way of living. How can you change that, And you can see, let's say an example, as Eric was mentioned. If it's an elder person in the hospital, he will not tell you that he's in pain. He will say, no, I'm fine, I'm okay. Because he wants to protect the rest of the generation to make sure they will stay strong. So we not see stoicism on a very negative way. We see stoicism as also a legacy of resilience in the community. Of course, our role as a physician is to make sure, because I'm a Rwandan, I can know when the patient is in pain, and I will treat physical pain even without saying. I don't need to ask, do you have pain? Can you scale your pain? No, as a Rwandan, I can feel that and I can treat pain. But I know what is the reason behind that on that sense. Eric?
Okay, so part of Palliative Care 101 that I teach my fellows is leave your agenda at the door, because everybody's different. In many cultures, as for example, for an example being the one that Dr. Christian described, patients may not complain of pain, but don't assume anything about anybody, go find out. And that may entail making it your business to learn about a local culture, but there have been very well-intentioned efforts to break down cultural barriers by saying people from this population think that way and people from that culture or that religion think that way. That's inadvertent bigotry, really, because everybody's different and you can't ever assume anything about anybody. So if I see a patient who I am sure is in pain, or I'm pretty sure is in pain in Rwanda or Vietnam or Russia or wherever it is, and the patient tells me, no, I'm not in pain, then I go find Dr. Christian, or I ask a local colleague, what's going on here? This patient seems to, I want to enlighten, help me understand what's going on. So Dr. Yoshimoto, just please don't assume anything about anybody, but recognize that in some cultures, what we call stoicism, what's called in Kinyarwanda kwihangana, is very prevalent.
Both for that. So Christina Lively, our education coordinator for the MMSc-GHD program, is in TMEC. She's also with a few of our other students, and they'd like you to sort of speak about your mentoring relationship that you guys have with one another. You did this fabulous interview for us where you talked about how the two of you met, but we'd like to know about your long professional collaboration a little bit. How do you keep the strong bond going? Anything you could talk about the mentoring relationship would be very useful for us.
Yeah, thank you, Merlin. So I came in the US in 2011 for the PSAP program, the Palliative Education and Practice. And it was coordinated by the later Andrew Billings and Susan Dubloc. And when I did the presentation about palliative care in Rwanda, Susan said, do you know Eric Krakauer? And I said, no, I don't know Eric Krakauer. But the last name was really difficult to pronounce because I don't know it's a Krakauer or Krakow, and I say, oh, it's a very good guy and they will help you. And he wrote an email and I met Eric. And when I met Eric, the first thing he said, oh, bonjour Christian, ça va? Tu as bien fait? Tu as bien voyagé? C'était bien? It was in French, and I was surprised to see an American speak French. And I felt very comfortable. And then we started to discuss. But I didn't expect many things from him because that time I was only 5 or 10 days of training on palliative care. And I read about him ton of publications. But the way he humbled himself to get on my level and say, I'm going to support you, and I remember I was invited to a small conference and I didn't know how to write an abstract. And Eric wrote the abstract and we sent the abstract. The abstract was accepted and I've been traveled. So all those simple things, I've never mentioned as Eric as my mentor. I think he's always we become more than, we become like a friends because I listen to him, and when we don't agree, we agree to disagree on some points. And we have both some of different divergence, but we always see what is the positive things we can learn from both others. So, and and as I said, as he taught me, one day student, one day master. So that was for me the best thing I've learned from him the last 10 years working together.
You want to, speak at all to that?
Well, I'm confused. Christian, I thought you were my mentor. I didn't know that I was supposed to be. I guess this is about, you know, I say that only halfway in jest because, you know, I think that it's really important to be curious, but to be open, to try to, it's like a full-time job, this business of openness to others. And I could go into that in great detail, but when I met Christian at Harvard, I was just so eager to go to Rwanda and to learn about Rwanda. And that was also partly because of what Partners in Health was doing there, and because of Joy and Paul's encouragement. But when I went there, you know, I was just asking questions all the time and wanting to understand what's the situation, how do people think, what, you know, okay, here's this patient. Where is she from? What did she have to do to get here? What's the insurance system? What's the family having to pay? Where's the family? Who's the family? Just a million questions. And what I discovered when I went there really was awe-inspiring. Christian, at the age of 29, had been appointed the director of probably the most important district hospital in the country, Kibagabaga Hospital, which he's mentioned because it was the hospital for 60% of the population of the capital city of Kigali. And he had taken a hospital with not very good health outcomes and turned it around. For example, greatly reduced maternal mortality and improved staff retention. And he had started a palliative care service and a pediatric palliative care program. He didn't mention that. He started a pediatric palliative care program at Kibagabaga Hospital. So when you know, as a Westerner and a Bostonian and a Harvard faculty member, I went to Rwanda and was in awe of the culture, of the history, the recent and more distant history, and of what Christian was doing and what the Ministry of Health was doing and what the ministers of health had done to make palliative care accessible. And I was filled with this idea of, oh my God, this is so amazing. The least I can do as a doctor, my job as a doctor is to try to relieve suffering and to help the sick and the vulnerable. And the most vulnerable are always the poorest. So here's an opportunity to do what I'm supposed to do, and also it's an incredible learning experience. So I think that's what motivated me is seeing what the country is doing with leadership of the Ministry of Health, what Christian has been doing, and feeling like I just want to help. I just want to take what I have and show me how we can do this. And let's do it as a conversation. And it's just so fascinating when you're doing this, when doing global health as a conversation with local colleagues. There's nothing that's more gratifying for me. And for anyone listening, I hope you'll be able to experience that.
You both on that point. I think that something that all of these alumni in actions have sort of highlighted, especially the ones between our alumni and their mentors, is just like the curiosity aspect for both parties. It's like, I'm curious about what you can teach me and vice versa. And, you know, I think when we're talking about strength of mentorship, it is, I see you as a person, I want you to teach me, I want to teach you. And it's a collaboration. And it's so neat to know that your collaboration has lasted this long and will continue into the future. So something that I'm curious about, and I'm getting a sense of curiosity in the Q&A, is like, how do you standardize care, careful care, something that isn't just like medicine, but it's thoughtful and culturally appropriate. Christian, it sounds like you're working towards that in this book. So how do you see yourself in the next 5 or 10 years, standardized careful care?
Oh yeah, in this 5 coming years, maybe working, taking the place of Eric in Boston. That would be great. I'm just
Watch out.
Careful what you wish for, Dr. Tazimira.
Oh yeah, I know. Yeah, so it's you know, I'm very surprised when it's also the question from Osman about adapting and adopting, and because it's easy when you know, we wear different clothes, we live in different houses, we drive different cars, and we find it normal. But when it's about care, we want one fit for all, which is, I'm very surprised sometimes on that. So the idea is, if we need to build a global, as that was the wish of Paul Farmer, we need to stand at local. It's like, you know, using that puzzle, some small puzzle, then at the end of the puzzle, you will see the picture, the big image on that. So on my sense, it's using what I have, I can share it to my colleague, and I can learn also from them. And I remember, it is a story I always share to Eric. When I came back to PSAP, the palliative care program in Boston, you know, I went back home with a big head because it was a program from Harvard. Then I remember I went to the patient, the first patient, I went there and they say, you know that you have a cancer? Did your physician told you that you have a cancer? And I disclosed all the information as I've been trained in Boston. And the next day, because I was the director, I had 16 people in my office from the patient family members. They came and they said, who told you to tell our patients about this disease? I was like, is it me? Is it the government? What legitimate? That was really the role, and but I forgot about the consent. I apologize to the family members. I apologize about what I did, and I tried to repair. And since then, you know, standards. Yes, standard is really good. If it builds the local, then the local will build the global. Because if we need to connect local, we need to connect identity as well. And from the identity standards, then we'll be building a global community.
Thank you for that, Christian. Joya, do you have a few words for us? You're muted.
I got it. Thank you. So thank you. You know, such a wonderful presentation from both of you, such important people in our Partners in Health and Global Health Delivery family. Just one, before I close, you know, one thought I have when we think about stoicism is to bring our own vulnerability to the table. My colleagues often say that as soon as you come, Joya, the patients start crying. And I think that's because I show my sympathy and my empathy very easily. Because I think some of the stoicism is the environment we create, whereby, you know, because of our suit and tie, because of whatever, we are distant. So sometimes I will start a conversation because I know, whether I'm in Liberia or Rwanda or Haiti, I know that a person is suffering. So rather than say, are you feeling pain? I say, you know, I'm sorry that you're suffering. This is really hard. And I think sometimes opening that dialogue in that way, I mean, you can't see somebody with a significant illness and think that they're not suffering, even if it's not pain. And I have found that openness, rather than going through a checklist, as you were saying, Christian, which you don't do, but I think sometimes we medicalize suffering to 1 through 5, right? Or suffering, you know, often when I say, I'm sorry you're suffering, I hear, oh my God, I don't know what my children are going to do without me. You know, or I hear, I'm so hungry, right? Or so it's a more open-ended way to approach suffering that brings our own vulnerability and what we see that is non-medical, that is really just about suffering. So, you know, I think when I think, you know, from what I've learned from both of you, you know, over the years and from my own work is that we need to think about palliative care in the most broad sense that we both do. And that also means that we have to be open to the suffering of others and even broken by the suffering of others, so that people will see us as humans, not as a sort of as a worker, you know. But thank you so much. These are such important topics. I think I hope we can take the idea of palliating suffering, alleviating suffering into all of our work, whether it is holding somebody's hand at the bedside, whether it's making sure they have food that they can eat, making sure, you know, I met my own grandmother fainted at my wedding many years ago. And in the ambulance, she said, it's because I didn't take communion this week. And that was her understanding. You know, it was hot. She had a vasovagal. I didn't say, no, grandma, you had a vasovagal episode. When we got to the emergency room, I said to the intern, who is now my long-term colleague, Emily Rowe, get a priest. Like, she's hooking up the EKG. I said, get a priest with a communion wafer, right? And like, that's thing one. So, you know, I think we need to think broadly about what palliation is and how to alleviate suffering, how to hear people where they are, and not see, you know, medicalize suffering as a linear thing. So thank you both. You're such champions of this around the world.
Thank you.
Thank you, Joya. Thank you, Christian. Thank you for making this possible.
Thank you.
Great to see you both. Christian, I miss you. I'll be coming to Rwanda in the next couple of months, so I'll give you
Okay. Be happy to
right.
see you again.
We'll have lunch. Okay.
Yeah,
And Eric, I
you.
got to see you this week, which was nice. All right.
Thank you. Thank you. Bye-bye.